So,
Good afternoon. My name is Rosanne Anguche. I want to welcome you once again to this webinar. And I want to introduce my presenter, that is Veronica Orina. She's a general dentist and has had a fellowship in hemophilia and other bleeding disorders in Cape Town, who is going to present on dental and bleeding disorders and hemophilia. We have Violet Antonia, Senior Nursing Officer at Kenyatta National Hospital, working in hemophilia clinic. Is going to talk about nursing management and in hemophilia. I once again want to tell you that we are having a series of hemophilia weekly, hemophilia and other bleeding disorders weekly from starting from last month, culminating to our hemophilia day, which is coming on 17th of April this year. So we just want to, we'll be having the event happening in KNH, and we'll have various and several guests coming in to celebrate with us and our patients. So I want to invite you to come and have a good day with us and just see and know what happens with hemophilia and what goes around about hemophilia and what hemophilia is, because this is going to be a great day for us, for our patients, and for those who will have come to just see what hemophilia is and what entails the management of hemophilia in KNH. Actually, KNH has done a lot of stride in management of hemophilia, and we are a world class. We are actually setting up a center of excellence in training, fellowship and training in hemophilia in KNH, and MTC has already picked up, but KNH is picking up very soon because it has already been awarded the center of excellence, and very soon we'll be having fellowships from other places and people coming in to train in hemophilia and other bleeding disorders. Thank you.
so thank you, Roseanne, for that introduction. We have our first speaker on board. Can you, Veronica, confirm whether you can hear us or whether we can hear you? Just speak.
I'm able to hear you.
Thank you. We can hear you loud and clear.
Yeah.
So, Dr. Orina, yes, we can see you sharing the screen. Can you put it on slideshow? We can see the screen. Wonderful, thank you. Yes, we can see it. You can proceed.
Okay, thank you very much for the introduction. As said before, my name is Dr. Orina, and I'm a general dentist who also has a very special interest in hemophilia. So today I'm going to take us through the dental care for patients who have hemophilia, because hemophilia is a special disease. So my outline is going to talk about the definition of the hemophilia, the dental care considerations that come into place when we are managing patients who have hemophilia. We're also going to see the most common dental problems that the hemophilia patients usually have. And we're also going to talk about their dental care in two aspects, which is one, preventative, and two, interventional dental care. So hemophilia is a coagulation disorder which affects the body's clotting factors and leads to prolonged bleeding. According to the World Bleeding Disorders Registry, we currently have a total of more than 1,000 patients. So it's usually expected that 1 in 10,000 males have hemophilia, whereas 1 in 5,000 have von Willebrand disorder. So the KNH hemophilia clinics is about 400 patients with hemophilia. So we are first going to talk about the oral manifestations, because majority of what we're going to talk about is things that involve the oral cavity. So for the oral manifestations, we have two types. We have the soft tissue manifestations, and you also have the most common manifestation, which is prolonged bleeding during and post extractions. So on the soft tissue manifestations, we usually have three major categories. So we have patients who present with petechiae, patients who present with ecchymosis, and patients who usually present with hematomas. So these pictures are a demonstration of the three soft tissue manifestations, which are purpura, ecchymosis, and petechiae. So usually they're one and the same thing, just that what differentiates them is usually actually the size. So for petechiae, we can see the first image on the left. They're usually very pinpoint lesions, which can occur anywhere, including the palate, the tongue, and the mucosa. So petechiae are usually less than 2 millimeters in size, whereas purpura are a greater size than 2 millimeters, and ecchymosis is usually the largest, which is more than 1 centimeter in size. So these are lesions that can occur anywhere in the oral cavity, could be the palate, the mucosa, and even on the gum area. So usually the hallmark sign of patients who have hemophilia is the disproportionate gingival bleeding following minimal trauma. And this usually varies from a patient who has mild hemophilia, moderate hemophilia, and severe hemophilia. So you're going to find that in patients who have severe hemophilia, they'll present with spontaneous bleeding, even without any cause, such as teething, such as trauma, or even a dental procedure. But you'll find that for patients who have a mild and moderate hemophilia, most of them, they have to have a cause which is triggering the bleeding. So in all patients with hemophilia, we'll have a prolonged bleeding after brushing or after flossing, and even after the dental procedure. Before maybe the hemophilia is diagnosed, this patient will have excessive bleeding if it's an undiagnosed patient and if they haven't been managed appropriately. Also, during natural exfoliation, we'll have gingival bleeding. And actually, we've had very many patients being diagnosed of having hemophilia through natural exfoliation, because for them, the bleeding is actually excessive as compared to other or the normal population. So again, we'll also have a bleeding that is usually difficult to control with the standard pressure techniques. So I know even with the procedure that we mostly carry out at the dental clinic, whether it's an extraction, if we have a patient who has prolonged bleeding, we are able to control using the local hemostatic agents like Surgicel, like suturing, and even a standard pressure pack usually works. But you find that patients with hemophilia, they might not respond to these, most especially when they've not had a factor replacement done. So I have pictures showing the site of gum bleeding. Here we have bleeding on the gingiva on the first image on the left, and you also have a patient who has bleeding on the gingiva. You see that metallic band there, usually an appliance which we use in the dental setup. So patient with a molar band there and has a lot of gum bleeding on the gingiva, which is actually not the case for a patient who does not have hemophilia. So because we are discussing gum bleeding, it's also important to note that there might be other causes of gum bleeding, and it's important as a clinician to know that other than hemophilia, other than the spontaneous bleeding that occurs in a patient with hemophilia, there could be also other factors that may cause gum bleeding. And these include poor oral hygiene, which is a major risk factors, because when you have poor oral hygiene, you have a lot of plaque buildup along the gums, and this patient will definitely experience bleeding gums, most especially when brushing. Can also have iatrogenic factors, like maybe doing a dental surgery, an invasive procedure for a patient who is an undiagnosed patient, or a patient who hasn't had the right hemostatic measures taken into place. Can also have self-injury around the gum region. Can also have traumatic dental injuries, like maybe a patient falls. They can have bleeding around the gum area. And we can also have shedding of milk teeth as one of the reasons as to why a patient, whether hemophiliac or not, will experience gum bleeding. So this is an example of a patient who has hematoma. On the very first image, it's a very small hematoma on the tongue, and it's actually a patient who was recently diagnosed at our facility because they could come with a minor bleeding on the tongue without actually any apparent laceration. And then querying by the history, it's a 9-year-old male who, when they come, they actually get infused with vitamin K, and then the bleeding stops. But then you'd find them maybe like a month later coming along with the same problem. So for this patient, we actually involved the nursing and the lab team. The samples were taken to KNH, and they actually came out with a diagnosis of moderate hemophilia A. So I usually like to say that the management of hemophilia is actually multidisciplinary. And when we diagnose hemophilia, it actually helps to improve the quality of life of the patient. And again, the patient actually gets to be managed appropriately. So you can have different sizes of hematomas depending on the trauma. You can even have very large hematomas like the picture I've shared of the lady there. So this is a picture of ecchymosis on the lingual region beneath the tongue. So as I said, bleeding can occur in any region. It could be on the mucosa, the tongue, on the upper lip, and the frenum, basically on every part of the oral cavity. It's good to know the dental problems that the hemophilia patients experience now that we're going to discuss about their management and their implications. So the most common problem, which is actually a very prevalent problem globally, is dental caries, otherwise known as tooth decay. So patients call it cavities. Patient present with cavitation on the teeth, and usually they come to you and tell you that they're having pain on the area. Maybe they can't eat properly, they can't feed properly. And these are patients who actually, because they can't clean well on the cavities despite brushing, they'll also present with a bad breath. So that's one of the problems. Also, the second most common problem in the dental field is called periodontitis or gingivitis. So this patient will also have a whole buildup of plaque, and this will, if not taken care of, it will progress on to be periodontitis. So periodontitis will manifest in very many ways. We can have a patient who has tartar or calculus deposits on the mouth, and if it's very severe, the patient can even have mobile teeth. So these patients, when it comes to hemophilia management, they have to be taken care of very well, and even have their factor replacement done before any intervention is done, such as debridement and full mouth scaling. So we also have problems with dental fluorosis affecting people who have hemophilia. We also have malocclusion, which is teeth not being aligned properly, which also manifests as crowding. So the management is divided into two parts. There's the prevention aspect and the intervention aspect. So let's just know that these preventative aspects, they actually apply to the general population. But when it comes to hemophilia is when now we have to take a few considerations on. So the general prevention of dental diseases is oral hygiene instructions. Usually instruct our patients to brush their teeth at least twice a day, and use a mouthwash when recommended, because we recommend a mouthwash only for therapeutic uses, but we don't encourage constant use of mouthwash because that also erodes normal flora. We also encourage our patients to use a fluoride containing toothpaste because it makes the tooth strong and less susceptible to dental cavities. And at the clinic, we can also do some things called fissure sealants to prevent the children from getting cavities, and also application of fluoride. So for patients who have hemophilia, we recommend that they use soft toothbrushes. That means that the bristles of the toothbrush have to be very soft so that we don't cause trauma to the gums. And we also have to advise on the technique. They don't have to be aggressive when they're brushing, so that we minimize the kind of trauma that we can cause. So whenever a patient has a dental appliance, could be a habit breaker or even braces, we also emphasize on a very good oral hygiene, because then if a patient has hemophilia and has poor oral hygiene, now the bleeding actually becomes worse. So we also encourage use of dental flosses and interdental brushes. For patients who have hemophilia, because flossing can actually trigger this, we can encourage them to use a oral tranexamic acid before, or even a tranexamic acid mouthwash, which is not actually available, but there's a way that it's usually formulated locally. So again, on the general of hemophilia, our patients usually has or knee joint disorder, so they'll have a difficulty in brushing their teeth. So for them, they can use modified toothbrushes and flossing aids. So this slide, I have a picture of the devices, which are modified toothbrushes, which the patients who have elbow joint disorders having hemophilia can actually use. And actually, I haven't seen this locally, but they're available in Amazon. And our patients usually use, most of them, they use the normal toothbrush. So for interventional dental care, in dentistry, we have a whole range of procedures which we usually provide, and that includes restorative procedures such as fillings. We also have extraction procedures. We also have root canal treatment, orthodontic treatment, periodontal treatment, and prosthodontic treatment. So I know that most of us are well versed with the extraction procedures, but it's good to know that there are other procedures that can be done, most especially when a patient has hemophilia. It's not just extractions, there are actually other procedures. So when it comes to restorative dentistry, this is basically where we perform procedures like root canal or fillings or even crowns. So it depends on the procedure that you're going to do. If it's a minimally invasive procedure, let's say, or even oral over fluoride, when we're doing procedures that require us to administer local anesthesia, then factor replacement is required, most especially for when we're doing inferior alveolar nerve blocks, most especially when we're doing treatment of the lower teeth. So we have to ensure that the patient has a factor replacement done before. So for extraction procedures, it actually depends, because as we said, we have three categories of hemophilia. There's mild, moderate, and severe. So for mild form, a drug that can be given is IV desmopressin. For mild and moderate forms, DDAVP. And for severe forms, it's factor VIII replacement. But these two are not available in the country. So we usually administer factor VIII prior to tooth extraction. Whether a patient is a mild, a moderate, or a severe, it's factor VIII that they get, and we're going to see about the factor dosages. So for extractions, it's recommended that the patient gets the factor 30 to 60 minutes before action. Are going to undergo as full mouth restorations under GA, we recommend that they have factor replacement before, because we may have a few injuries due to intubation. So also for patients who have inhibitors, this one we usually coordinate with the hematologist to advise on the factor dosages before dental treatment. But I personally, I haven't come across a patient with inhibitors. Most of the patients I've seen are actually patients who have hemophilia and who respond to factor VIII or IX. So usually for hemophilia A, the factor dosages are 20 to 30 IUs per kilo. And for a major procedure, it's 40 to 50 IUs per kilo. So as a dental professional, it's very important to know this, because as you coordinate with the hematologist, you can also assess the risk, or rather like how invasive the procedure is, so that you can also be able to advise the doctor or the hematologist or the nurse on the dosages. Because suppose it's a simple milk tooth with grade 3 mobility, the patient doesn't need you don't need to calculate from 50 IUs, because that's for a major procedure like a wisdom tooth extraction or an impaction. But for a simple milk tooth extraction, let's say there are moderate hemophilia A, you can calculate from 20 IUs per kilo. So for hemophilia B, the factor dosages are 20 to 40 IUs per kilo for a minor dental procedure, but for wisdom tooth removal, it's 60 to 80 IUs per kg. So after extraction, these are the instructions that we usually give our patients, and those are to observe the patient for an hour, tell the patient to avoid extremely hot foods and extremely hot drinks, and also to do adequate gauze compression. Usually 30 minutes is okay if they have received a factor prior. And usually, depending on the availability, it's recommended that they use systemic or topical antifibrinolytic agents for 5 to 7 days. I know in other countries like South Africa, they usually give IV factor for 5 to 7 days, but here in our country, because it's not available, we usually do the IV on day 1, but then the rest of the days, depending on how mild or how severe it is, we can either do alternate IV factor or topical, like tranexamic acid. So we also advise the patients to refrain from sports and intensive exercises, to eat a soft diet, and no vigorous mouth rinsing for 3 to 5 days, because then when the patient rinses vigorously, it means that we might dislodge the clots that we are already forming. We also advise the patient to refrain from or reduce the smoking for at least 24 hours, so that we don't interfere with our healing. So orthodontic treatment is divided into two. There's removable and there's fixed. So I think this is what generally people call braces. So just want to say that braces treatment or orthodontic treatment is not contraindicated in hemophilia. It's just that there are special considerations that you have to consider. For instance, it's better to do direct bonding or fixed orthodontic treatment as opposed to removable appliances, because we have less trauma to the palate or to the gums. So we advise on direct bonding as opposed to fixed molar bands as well, and that applies to the buccal tubes or on the 6s or on the 7s, and also whenever possible, self-ligating brackets are preferred over conventional brackets. So for periodontal treatment, for scaling and root planning and full mouth debridement, factor replacement is required. And for a simple scaling and polishing, none is required. But when we're doing a very thorough dental examination, which is going to include periodontal probing, plaque control, and oral prophylaxis, factor replacement is required, and oral tranexamic acid. So for prosthodontic procedures, which involve only dentures, things like dentures, they are actually non-invasive procedures, so factor is not required. It's only important that the clinician takes a lot of care during impression taking, so that we don't cause trauma to the gums. So complications that may result from having hemophilia and in a dental setup are like excessive bleeding after an invasive procedure, most especially if it's not well managed. And you could even find that maybe it's a patient who has inhibitors and they're not responding to factor 8 or 9. So excessive bleeding can happen. And when this happens, you just have to use your local hemostatic agents in your dental setup, and also consult the hematologist. So also trauma can result in excessive bleeding, most especially because for us dental professionals, we usually use suction. So if you use high volume suction, that can actually traumatize the buccal mucosa or the gums. Can also have muscle bleed or hemorrhage, but this is not very common in the oral cavity. And other abnormalities or joint and muscle arthropathies are also some of the complications of patients who have hemophilia. And another general complications is development of inhibitors against clotting factors. So issues that may result from a patient having hemophilia are such, because majority of these patients are actually afraid of visiting the dentist. So they don't get, they don't seeking behavior, maybe present with this patient are like gingivitis, and also on the image on the middle is actually a patient who has a milk tooth and an embedded permanent tooth there. So you find that most of the patients in the normal population, they actually come and they get this removed. But for patients who have hemophilia, they might be afraid to even come to the dentist to get this removed. But I believe that currently a lot of emphasis is on dental care. So I believe that we are changing that currently. So management of oral bleeds now in a dental setup, most especially because now for the factor, that's another department from what I understand from very many institutions. But now in a dental clinic or in a dental setup, management of oral bleeds usually relies on these four major principles, and that is, one of them is adequate planning. So thorough preparation for emergencies. And also we have to equip our facilities with local hemostatic agents. The most common ones that I see are usually the Surgicel and the gelatin sponge and even the bone wax. But bone wax is a bit extreme, most especially in surgeries. It's used mostly in surgeries. But the most commonly available drug is the tranexamic acid, I believe in many hospitals. So there's the per-oral formulation and there's the IV formulation. So this comes in very handy. Also, local pressure application is very important, most especially when it's combined with a small bit of adrenaline. So suppose the extraction socket is big and you anticipate bleeding, you can actually suture the extraction site with an absorbable suture, such as Vicryl. So emergency care, even as you try to manage the bleeding with your local hemostatic agents, it's very important to contact a hemophilia treatment center or a hematologist. So we have two comprehensive centers in the country, which are KNH and MTRH, but there are very many hemophilia treatment centers, which I think more than 17 in the country right now. So for hemophilia patients, antibiotics are not contraindicated. But for analgesics, we usually advise against non-selective or selective non-selective NSAIDs such as ibuprofen. So we usually recommend drugs such as Panadol or codeine-based drugs like or like opioids such as tramadol. So out of these slides, we can just carry home that we don't recommend non-selective NSAIDs such as Brufen and mefenamic acid. So this is just to tell us that these antifibrinolytics are available for dental use, and those include the majorly two, tranexamic acid and cyclocapron. But cyclocapron, I've never seen it in the country, so what we usually use most of the time is the tranexamic acid. And maybe if you ask me about how to manipulate that mouthwash, it's usually you pour a small amount of the IV to normal saline, and the patient can actually use that to rinse. For procedures that actually are very minor, like minor scaling, the patient can actually use this, or even before flossing. That's also an indication. So I think that's what I had for today. I'm looking forward to your questions. Thank you very much.
Thank you, Dr. Rina, for the informative presentation. I want to welcome our second presenter, who is going to present about nursing care in hemophilia. Thank you. Welcome, Barbara.
Good afternoon, everybody. My name is Violet Atonya. I'm a nurse at Haemophilia Clinic at Kenyatta National Hospital. Today we are going to learn about nursing care in hemophilia. First, we have learned that hemophilia is a bleeding disorder which is caused by clotting factors, which is deficiency of factor 8, which is hemophilia A, and deficiency of factor 9, which is hemophilia B. All this leads to prolonged bleeding. They bleed for a very long time. So it's an recessive inheritance, which means the X chromosome is the one which is passed to the next generation. It mostly affects males because they inherit the X chromosome from the mother, and the mother must be a carrier. So females are usually carriers. Okay, let's say about the genetics. Hemophilia is usually inherited, as we have said, through the X chromosome, which is a factor 8 or factor 9 gene mutation. 70 of the cases result from spontaneous genetic variants. And hemophilia actually affects only males who inherit the X chromosome from their mother. We know the father carries XY and the mother carries XX. So the father will only pass the Y to the boys, and the mother will transfer the X to the boys. So the X chromosome which is affected is from maternal side. Females with hemophilia are rare because they have to have the two X affected. So what happens when the mother is a carrier? There's a possibility that 50 of the sons will get hemophilia and 50 chance daughters will be carriers. And when the father is an hemophilia, we have no son will have hemophilia because there is no X that is going to transfer to his sons. But 100% of the daughters will be carriers because they have inherited the X which is affected from the father. And in case the father is hemophilic and the mother is a carrier, 50% of the son will be hemophilic, 50% of the daughters will be carriers, and this when we get 50% of daughters who have hemophilia because the two X they have taken from the mother and the father are affected, so they become hemophilic, which is a rare condition. We have never had female who are hemophilic. So what does a nurse do when the patient comes? We have known that after diagnosis, the patient comes and the first person the patient meets is a nurse. So it's the nurse to do the genetic counseling. Now that they have the results and you have seen the results, APTT is raised, they have said they have done the assays and they say this hemophilia A or this hemophilia B. So why do we do the genetic counseling? It helps to understand the condition for the family. It identifies the carriers. So when the parents come or those who have brought the patient and they have those results, we sit them down. We start now talking about the genetics. Now this when we tell them the father cannot transmit the X chromosome to the son. So the maternal is the one who has the X chromosome which she transfers to the boy. So you start now from the mother. And you have to be very careful because this is the time when you are doing that, immediately the father hears that this X was brought from the mother. This condition is from the maternal side. Some of these men they walk out as if they are going to the toilet and that's how they go forever. And many of the hemophilic boys are being taken care by single mothers. So after doing that, you teach them how they are going to live with that disease because it's a life condition. They'll have to stay with it until the end. So you teach them how they are going to get the factors. You tell them, you now go to the side of the mother. You ask them if they have sisters and do they have boys. If they have boys, they come for screening. And screening is being we have a donor who takes care of the coagulation profile. So every patient that comes or every client that comes for screening, they are being screened, and that's how we get our patients from the mother's side. So in case you get a boy, you just know it's from the mother's side. He has gotten the X chromosome from the mother. You leave about the father. So what do we do when the patient comes? You do assessment. So what do we do in assessment? You take a history, you do a physical examination, you see if the joints are swollen, the muscles, are they painful? And you have to actually, even the kids, you have to do head-to-toe examination, because you can find a mother coming with a small baby, like 9 months, then it's now digital era, where the house girls are being left with the kids. They watch the kids. The mothers don't actually touch the kids. They just come to breastfeed. So the mother comes with a kid. Oh, my son is just crying. I give him breast milk. He doesn't want to take. I don't know what is wrong with him. So when you do physical examination, you find that he has a gluteal muscle bleed, a very big one, and the mother has not even seen it. So it's very important to do physical examination. Then you have the lab results. You see if the APTT was prolonged, and you see the clotting factor levels. So how do we take the history? How do we do the history taking? You do a bleed safe. So B stands for bleeding history. You ask the patient which type of hemophilia do you have. If they know, or you check on the results. You check the joints if they are swollen, if the muscles they have muscle bleeds, and the gums, nose. You check all those. Then frequency and severity. We know there are types of hemophilia where it can be severe or moderate or mild. And you ask if it's spontaneous or it came after trauma. Then you go to location. Where is the bleeding coming from? And does he have joints bleeds? You check the muscles, and you check if he has internal bleeding. This one you can do by doing vital signs. If the BP are low, you will know he's having internal bleed. If the pulse has tachycardia, you will actually start querying bleeding, internal bleeding. Then you'll ask them if they have urine if they have blood in the urine, if they have a hematuria or stool. So their stool, they'll tell you it's black, or they have fresh blood in the stool. Then you go to the episodes, the past history. You ask them the previous bleeding episodes. Has he been having these bleeds? Any admission to the hospital, and any complication. You see if the joint has been damaged, and these are the patients who have disabilities. Then you go to drugs. You ask them exposure. What are the triggers? Is it the trauma? Is it surgery? Have they had dental extraction or any recent injury? They will actually tell you, last week I had a surgery, so you will know this patient bled because of surgery. Then there's drugs. You ask them if they have gotten any factors, if they have taken any NSAIDs or aspirin. We know that they are not supposed to take aspirin or NSAIDs. Then you ask them if they are adherent to treatment. Have they been coming for treatment? If they have those joint bleeds or muscle bleeds, do they come to the hospital? Then you do a surgical history. You ask them if they have had any surgeries or tooth extraction, and was the bleeding excessive? If it was excessive, what were they given? Then you ask them their daily life. How was the bleeding impacted on their mobility? Have they been walking well to the school? If they are children, if they are adults, have they been going to place of work? Have they been using crutches? Have they been, how have they been walking with their joints? Then you ask if there is joint stiffness or any deformity. You'll just see. Then emergency, the severe bleeds like intracranial, abdomen. So in case of this severe bleeds, they are supposed to be admitted, especially if they have intracranial bleeds. They'll come with the vomiting, drowsiness, headache, blood visions. Immediately they tell you they have that, you must sense these are intracranial bleed, and you give factor at 100% before you send them to CT scan or blood slides. Just give them factor before they do the investigations. Abdomen, are they having GIT bleed? If they are vomiting blood, if they have blood in their stool, are they having fresh blood? So you have to give them 100% factors. Then you check for signs of shock. That's by doing the vital signs, as I've said. And okay, we go to nursing diagnosis. These patients have a risk of bleeding due to deficiency of clotting factor, factor 8 or factor 9. The same patients will come with acute pain due to swelling in the joints and muscles. As they tell you, I'm having this pain, so you use the pain scale to know how much pain they're having and how are they moving. Do they have limited movements? Then these patients have impaired physical mobility related to joint bleeding because of pain and swelling, as you see them having difficulty in movement and reduced range of motion. They also have risk for injury. This due to increased bleeding tendencies. And once they get more frequent bleeds, they usually tend to have fragile joints and the bleeding is always frequent. Then these patients and the family are always having anxiety due to fear of bleeding episodes. So the parents have anxiety, the children have anxiety because of the bleeding. Because we have seen the spontaneous ones, they can just sleep and in the morning, you find all the bed is bloody. So they are worried. So what do? If the patient comes with bleeding, you give the clotting factor, you replace it according to prescribed therapy. We were given the dosages by the pharmacist. Then you apply a direct pressure to bleeding sites. You can pack with the tranexamic acid. If it's an open wound, you pack with the tranexamic acid. Then you can use cold compressors. You know, it makes the vessels to constrict. So it's good to use the cold packs. Then immobilize the affected limb. How do we do it? They can be splintered. You can put them in a bed, not use that affected limb. Then you monitor for signs of internal bleeding. That's the pressure, the pulse. Then we have said another diagnosis, pain management. So how do we do with the pain? You administer the prescribed analgesics, and we always advocate for paracetamol and Panadol in severe pain. You avoid NSAIDs and aspirin. Don't give to hemophilic patients the NSAIDs and aspirin. Then you can use cold packs intermittently, 5 minutes, then remove, put again. It will actually relieve pain. Then you elevate the affected limb, put the affected limb on a pillow and provide rest. So that's what we call RICE. RICE, it's rest. Then you use ice, you compress, then you elevate the affected limb. Okay, this patient has anxiety and the relatives. What do? You teach them how to recognize early signs of bleeding, especially those who have joint bleeds. They'll actually tell you they have a tingling sensation in their joints. So immediately they have those signs, let them come for factor in the hospital. And you teach them importance of adherence to treatment. If they come for treatment early, they will avoid damage to the joints of the muscles. Then you tell them to avoid contact sports like football. Let them have these simple sports like swimming, something like basketball. They are not supposed to play because of the injuries. Then how you teach them on home management of minor bleeds. And that's when we tell them about the RICE. They should rest that limb. They put ice. They put they compress. Then they elevate that joint so that before they come to the hospital, they have done all that. Then you continue with the genetic counseling. Then we have these patients, they usually, some go for surgery, and you have to prepare them for surgery. They don't just come and they go to theater like any other normal person. So this involves a thorough review of various aspects of patient's condition. So you should know the hemophilia type. Is it factor 8? Is it factor 9? Before the patient is taken to theater. You see the severity of the patient. If the patient is severe, you should know you are going to use a lot of factors than the mild hemophilia patients. Then you confirm the details of patients, those who have been on prophylactic. We have patients who are on prophylactic like Hemlibra. So those patients, their dosages are actually low. We don't give them factors like any other patient. Then you do an inhibitor screen before they go for surgery. Why do we do an inhibitor screen? So that we can know if the factors will work. Then you do normal blood works like a full hemogram to know the HB. If it's low, they need transfusion before they go for surgery. You do UECs because we know after bleeding there is a poor kidney perfusion. So you have to do all those and you repeat the coagulation profile to see how levels of factor in their bodies. Then these patients, as they go to theater, you have to replace the factor by 100%. So you calculate the dosage as we were told, weight times the desired level, then times 0.5, if it's factor 8. And if it's factor 9, it's weight times desired level of factor you want to replace. So 20 minutes after replacement therapy, after giving the factor, they should recheck again. You do the coagulation, you see the levels, so that if the levels have not gone up, you repeat again the factor infusion. Then with the lab results of the drawn sample, replacement of factor percentage is done during surgery. So just stop up until the surgery is over. Then after surgery, what do we do after the patient has come from surgery? You continue with the factor replacement. So when the patient was going to theater, you give 100%. Then after surgery, after 2 hours after surgery, you give another 100%. factor replacement. For the 2 days, you should be giving 100%. Then the third day, you can now temper down to 60%. As the patient recovers, you go to 40, then you can leave the patient to recover. Then pain management, you start with the strong opioids like morphine, fentanyl, then you go down to weak opioids. So you can give tramadol, then scale down to non-opioids like paracetamol, meloxicam, and other adjuvant methods. So we have said you avoid NSAIDs and aspirin, you avoid them completely. Then you use normal saline when dressing this patient so that you soak that dressing very well before you remove, so that it can easily be removed. Because in case you force it, that clot, in case there's a clot, don't remove that clot. We advise you just put normal saline and you cover it. Because if you remove the clot, the patient will bleed. You can actually use tranexamic acid when you are dressing to reduce the bleeding, because tranexamic acid actually makes the clot stronger. Then you use topical application antibiotics, cream for faster healing. In cases of bleeding, dressed with a light gauze. Why light gauze? So that you can be able to monitor if this patient is bleeding. Then you use ice pack in management, like when patients, actually hemophilic patients, when they are going for circumcision, they don't just go any hospital. We have a medical circumcision, we plan it, and when they come to the hospital for circumcision. So after circumcision, these patients actually bleed, and when they're in the wards, during erections, they bleed a lot. So we give them ice pack to put, especially in the 5 a.m. in the morning when there's erections, to avoid the bleeding. Some patients develop inhibitors. So when they develop inhibitors, or if they come with inhibitors, they will get fiber, which is a bypassing agent, and it will be administered daily until healing is, the patient recovers completely. So conclusion, early management and early diagnosis of hemophilia prevents complications, because these are the patients who get damaged joints. They start using wheelchairs, they start using crutches. So to avoid that, you start early diagnosis and early management. Then these are lifelong care, which is required. So you have to tell the caregivers that this condition will take the whole of the patient's life. So they need to take care of the patient until the days God has given them. Then nurses play a key role in patient community education, prevention policy development, and advocacy initiatives. So we go out to schools to teach teachers and students on how to take care of these hemophilia patients, because most of the patients come with gluteal muscles bleeds because of being pained by teachers. And we go even to churches and outside there to communities to teach them about the hemophilia. And what I'm doing now, we are teaching you about the hemophilia so that we can get more and more clients of hemophilia. Then nursing care at the primary level saves lives. Thank you for listening.
Thank you, Sister Violet, for the informative presentation. It's now time for question and answer. I want to invite each and every one of you who have any questions. I want to open the chat so that we can be able to reach out to our questions and So I want to welcome each and every one of you who has any question to write it in the chat. It's time for Q&A, so I'll invite each and every one of you who have questions to please put it in the chat box so that we can be able to respond to them. Okay. The first question is ask Dr. Rina to share the contacts so that we can reach out to her. Dr. Rina will write the contacts in the chat box so that everyone can be able to reach out to her. Then which is the best toothpaste to use once you notice brownish dental decay? I think that one will be responded to by Dr. Rina. I'll read a pack of questions. Dr. Rina, you can answer that.
Thank you, sister. So generally, we usually recommend that you use a fluoridated toothpaste. Actually, I don't want to point to a brand, but most of the toothpaste that are available, like Colgate, Pepsodent, all of them actually have some fluoride. But when a patient has a brownish dental decay, it means that they might need interventions such as dental fillings. So I'd advise that they visit a dental hospital or clinic so that the same is addressed.
Okay, thank you. Do hemophilic patients live to old age?
Yes, we have a 70-year-old patient with hemophilia. This patient live a normal life so long as they get factor, so long as they take care of themselves as they come to the hospital for checkups. And anytime they have a bleed, they come for factors. They stay like any other normal person. And we have many adults over 60 years, they are there.
Okay, there's another question that says, what's the genetic explanation of a Down syndrome child with hemophilia, and why does hemophilia affect X chromosomes? Violet? Okay, hemophilia is what I can respond partly to that. Hemophilia affects X chromosome, that is the chromosome that comes from the mother, and the mother inherits it from the father. So the mother just passes it to the son. So if a son has an X chromosome that is affected, the father, that son, when he becomes he grows to old age and gets children, he passes the affected chromosome to the daughters. So I find that the daughters are the host of the X chromosome. Hemophilia trait is rested on the X chromosome. So that is how it is passed down to the sons. How do we approach airway management of hemophilia patients with Lafort 3 due to RTA? Dr. Rina, I think you can respond to that.
Sister, please pardon your question.
How do we approach airway management of hemophilia patients with Lafort 3 due to RTA?
Okay, so I believe this is a department called maxillofacial surgery, because Lafort-3 are a type of facial bone fractures. So most often the patient who has Lafort-3 fractures requires open reduction and internal fixation and GA. So every preparation for this patient happens like in the usual way, but they have to get factor replacement, which is 100%. So for that, you'll calculate with the highest dosage, which is 50 multiplied by the kgs, so that we raise the factor level to 100%. But then, because it's a very invasive procedure which is done under GA, this patient has to get a systemic factor level for the next 5 days. IV, there has to be clotting factor concentrate for the next 5 days, even after the procedure.
Thank you, Dr. Rina. There's a question that says, kindly elaborate a bit on medical management and drugs, period of administration, and the interaction with others. I believe, Dr. Rina, you can respond to that. Kindly elaborate a bit on medical management and drugs, and period of administration and the interaction with others.
Okay, so the most common drugs that are administered are factor 8 and factor 9. So I'll post the factor dosages on the chart, but it's important to note that for factor 8, usually when you administer one international unit, it raises the factor level by 2%. And for factor 9, it raises the factor level by 1 to 1.5%, but I'm going to post our factor dosages on the chart.
Thank you. The next question is hemophilia patient at risk of having sickle cell? I think Dr. Violet can answer.
No, if a patient has hemophilia, unless the parents or the family has an history of sickle cell, is when they can get sickle cell. But hemophilia has no relationship with sickle cell because hemophilia is a gene. It's a gene which is passed from the X chromosome, unlike sickle cell.
Thank you. I want to know that are hemophilia patients given factors to use at home when they are injured? Are they taught to insert a branula?
Yes, as we do genetic counseling, we usually teach our patients on how to do self-infusion. And the drugs which come, they come with everything. They have a scalp vein, they have water for injection, they have a swab, and a patient we teach them how to mix and how to give themselves that, they know how to look for veins and give themselves the drugs, because we give them drugs to go with them at home because of the bleed they have. It's severe and they don't need admission. We give them factors to go with them at home, and we teach them on self-infusion. In fact, we have a 9-year-old boy who knows how to infuse. He can look for his own veins and infuse himself.
Another question reads, how long do you wait after factor replacement? Violet, you can answer. How long do you wait after factor replacement?
For patients undergoing surgery, we give factor 30 minutes before they go in, then 2 hours after they have been done the surgery. As they go to the ward, we give them factor. So depending on the factor, like factor 8, it's a half-life. It's 8 to 12 hours. So we give daily. We replace it daily for those days that the patient is still recovering. Factor 9, it takes like 12 to 18 hours. So 16 to 18 hours. So we usually give we give daily, but sometimes we skip one day.
Okay, there's a question that reads, do we have men who are carriers of the disease, or for men, it's either they have the disease or they are not? Okay, the men are patients while women are carriers. It is carriers who give birth to the patients. mostly when a man has an affected X chromosome, they pass it to the lady. They pass their X that is affected to the women, and to the women, to the ladies, or to the boy, to the girl child. So when they grow up with the gene that is already suppressed with another X chromosome, so they're the carriers. But when it's passed to the men have only one X. So the X that they have is the one that exhibits the signs and symptoms. So men are the patients, while the ladies are the carriers, because they have an extra X that suppresses the affected X. Okay, thank you. Thank you very much. I'm seeing this is the end of our question and answer time. And I want to really thank you for having been in the session, and want to invite you to the World Haemophilia Day that is 17th of April 2026, this month. And we'll have our celebrations in KNH. So if you'll be around on that day, please avail yourself for the celebrations. Thank you. After those things, and the type back.
Yes, Dr. Orina, thank you for the wonderful presentation. Thank you also, Violet Atonia from our Haemophilia Clinic. And also thank you to our moderator today, Madam Anguche. We've had a wonderful session. If you're still on the chat, kindly note that Dr. Orina will be posting the
factor dosages
on the chat, so kindly stay for that information. If you for those who are needed elsewhere, please note that this information will be posted together with other content on our YouTube page. For now, I'd like to let you know that we'll be having an evening session today where we'll be looking at colorectal cancer, and we'll be looking at the rise of colorectal cancer in millennials, and how to give care to stoma patients who are currently being treated for colorectal cancer. So thank you once again for joining us today. We'll be back today in the evening. That is at 7 p.m. Nairobi time. Kindly do join us. For those still on the chat, kindly note that Dr. Rina will be posting the factors on the chat. So kindly stay with us until she does that. For those who need to be elsewhere, kindly note that this also will be posted on our YouTube channel together with the upload of this video. Asanteni sana.